Type 1, today is type 2. Tamam? Very important, very conceptual. Now here, just quick summary. Type 1. What were the characteristics of type 1 hypersensitivity?
Antigen based.
Antigen based. Very good. Antigen is coming from outside. Antibody is present inside the body. See here. And then how many types of the mechanism, the cellular reactions? Three things are occur. Number 1, immediate degranulation. Number 2, prostaglandin from the phospholipids. Number 3, DNA dependent. Clear? These are the 3 actions. Here, type 2. Now, the technical thing here in the type 2, there is, what is this one? This is a cell, host cell, any host cell, antigen presenting cells. What is this? Antigen. How it is presented on the cell surface? By the MHC. Very good. And this is, now keep this word in your brain, then there will be something and then you will remember my words. This is a short peptide antigen which is present on the MHC, and MHC bring it on the cell surface. So the situation is that antigen is fixed on the cell, and what is coming? Antibody is coming and attaching to it. Antibody is coming and attaching to it. Clear? Here the situation was that antibody was on the cell and antigen was coming from the outside. Clear? So what will happen then? Type 1 we discussed this. Type 2 hypersensitivity, it is the antibody mediated hypersensitivity. Antibody mediated. That is the disorders caused by the antibodies directed against the target antigens on the surface of the cell or other component. The antigen may be normal molecules intrinsic to the cell membrane or extracellular matrix, or they may be adsorbed exogenous antigen. For example, sometimes the cells they have antigen, but that is self antigen. The body don't do anything to them. The body don't create any problem to those antigen. Tamam? For example, RBC, what is your blood group? Blood group? A. What antigen is on your RBC? A. And what antibody you have? Tamam? So, and sometimes the antigen they are present on the RBCs. They are present on the RBC. But they don't create any problem. Our body don't create any problem to these antigens. We don't kill our own blood. But sometimes what happens? We take some medicine. And the part of that medicine moving, going and attaching to that blood group antigen. You understand my point? The part of that antigen, your son is very good. He is a nice gentleman, Mumtaz, going to masjid, going to school. But one of his friend came from outside, had a friendship with your son, and then he made kharban your son. You understand my point? This is called adsorption. So sometimes the normal bodies are there, normal antigens are there, we don't have any problem with that, but when it is attached with some other thing, then it is a foreign thing and the body system against that own antigen. Clear? So there are different things. Normal molecule, membrane in the extracellular matrix, or they may be adsorbed exogenous antigen by the drug molecules, and then they become antigenic. Then the cell become antigenic. Okay, type 2 hypersensitivity, also called cytotoxic hypersensitivity. Antigen are normally endogenous, although exogenous chemical haptens, we discussed drugs that can attach to the cell membrane and can lead to type 2 hypersensitivity. Primarily mediated by IgM and IgG class. Which Ig will come when there is an infection? First. IgM will come first. Why IgM will come first? Because it is a bigger molecule, pentameric molecule. Then it is phagocytosed by the cell, killer cells, phagocytosed or by the killer cells, or may play a role there, and the reaction times is minutes to hours. Immediate reaction 15 to 30 minutes, and then it is for the longer duration from minutes to hours. Now, three things occur anti-mediated problems caused by it causes three major steps. The problems occur in the three major steps. Number one, cell death with the help of opsonization and phagocytosis, but no inflammation. The cell will die, but there will be no inflammation. There will be opsonization and phagocytosis. Point number two, there will be a killing of the cell with the help of complement receptors and with the inflammation. And last but not the least, there will be antibody-mediated cell dysfunction, functional derangements will be there. So, cell death without inflammation, you have, for example, I can give you, let me give you some pictures out here. Okay, this is, we'll give you some idea and then we'll go to this. For example, it is done with the erythrocyte, platelets, all these things. Will take you to here directly to the picture. For example, just see, this is red blood cells. Tamam? Red blood cells is attached with the antigen. Some antigens are there, they have attachment with the red blood cells. For that red blood cells or any cell which has an antigen and some drug activate that antigen, so there can be two mechanisms. The antibody will come and attach to that antigen with the receptors, with the antibody, with the epitope. Either this antibody by itself attached to the macrophage and then macrophage will eat it. Tamam? It will make an opsonization and macrophage will eat it. Like this one, this mechanism. It comes to Fc receptors with the antibody and then it will be engulfed. It will be engulfed, phagocytosed. Or antigen is there, antibody comes and attached with the antigen, tamam, and this antibody has an Fc portion. This will activate complement. This will activate complement. When this will activate complement, instead of making the whole complement activation, it will synthesize C3b. And you know C3b, function of the C3b is opsonization. So this will be a killing of the C3b. With the help of the C3b, it will again engulf and destroy the cell. Clear? So two mechanisms, no inflammatory process is required. Phagocytosis by antibody directly or phagocytosis with the help of the complement. Two mechanisms directly, they cause the phagocytosis. So here, for example, if you see here, antigen, antibody, macrophage. Antigen, antibody, C3b, opsonization, and macrophage and phagocytosis. So two mechanisms of the phagocytosis, one with the antibody directly, another with the complement, So two steps. Steps number one, cell death by phagocytosis. Cell death by phagocytosis or removal of the cell by phagocytosis directly with the antigen antibody complex or involvement of the C3b, which is the complement component. Clear? Third component is antigen is there. Again it activates, the antibody will bind with it, but now it will activate the complement system as it done again. Earlier the complement was stopped at C3b, now it will not stop at C3b. It will say, okay, I am enough to kill it directly. I am enough to kill him directly. So what it will do? It will make what? It will make MAC, membrane attack complex. When it will make membrane attack complex, it will kill the cell directly. It will kill the cell directly. Is this clear? So antigen, antibody, complement system, MAC formation and cell death. Come on, huh?
Without phagocytosis.
Without phagocytosis. Without phagocytosis. Clear? Fourth mechanism or third mechanism is the mechanism where antigen is there, antibody is there, but they stimulate a specific type of the cell. That specific type of the cell, what is the name of that specific type of the cell? Last one. What is the name of that specific type? Come here. Come to the front. Come here. Come here. I don't know well you will understand. You are not going to understand. What is the name of that specific type of the cell? Killer cell. Killer cell, natural killer cell. The killer cell will say, okay, no problem. When this is the antigen, this is the antibody, it will come attached to the antigen. Tamam? This is the natural killer cell. It will come and attach to the natural killer cell here. You know, there are some type of the snacks, they don't sting, they don't touch the human being, but even from far they spit venom. You got my point? They spit venom. Here this antigen when attached to this natural killer cell, this cell don't attach with the cell, with the host cell, but they release some compounds. They are called perforins. They release some compounds. These compounds rupture the cell and lead to cell death. Lead to in MAC, what was the mechanism in the MAC? The MAC was a drilling mechanism. The MAC was a drilling mechanism. There was something which is attached to the cell membrane and it make a hole in the cell membrane. But here in this case, they don't make hole with some mechanical thing, but they make some chemicals and that chemical rupture the cell. Clear? So this is one. This is the second component, phagocytic cells. Here is this is the membrane, this is the target cell, antigen is here, antibody is here, C1. If I ask you what is the single common significant characteristics of, some of the question will be like this, all answer will be correct. All answer will be correct, but one will be the best answer. So be prepared for that. For the complement, now I am giving you some options. Complement is attached to antibody, true or false? True. Complement can be attached to macrophage cells, phagocytic cells, true. Complement can cause opsonization, true or false? True. Complement C1, Q, R and S are attached, Q attached to the antibody. Q attached to the antibody. If I ask you guys which one is the single best characteristics of the classical complement pathway? The last one. So be prepared for some of the questions like this. So here you see this one, this is the second component. We discussed phagocytosis, two mechanisms with the C3b and direct antigen, and third one is this is complement and this is MAC, and MAC is killing directly. Clear? And last but not the least, here, and this is C3b. This is C3b. See here, this is target cell, antibody attached to it, that activate the complement system, and here shifts C3b, and these C3b attached to it, and this causes opsonization. This is called opsonization. So two mechanisms with the phagocytosis, one mechanism with the MAC, and this is the last mechanism. This is the last mechanism. This is again the MAC. Sorry, this is again the MAC. This is again the MAC. Antigen is coming, antibody is attaching to it, C1q attach, C1r, C1s, then membrane attack complex, and then rupture. Clear? Now this is the last one that we discussed by the natural killer cells. This is the target cell, these are the antibodies, and here is the NK receptor and natural killer cells. Natural killer cells. Once it is attached to this natural killer cells, when it is attached to the natural killer cell, it releases some chemicals. It releases some chemicals, and then these chemicals will rupture the target cell. These chemicals will rupture the target cells, like this. See, this is Iva. See here, attached to the receptor, and then clear, guys? So 4 mechanisms we discussed very clearly. 4 mechanisms we discussed very clearly. 2 phagocytosis. Why I am repeating all the time? Because this is very important. 2 phagocytosis, antibody C3b, another MAC. Last one is by the natural killer cell. Okay. Type 2 hypersensitivity reaction, some diseases, autoimmune hemolytic anemias, when there is an RBCs, autoimmune neutropenia, thrombocytopenia, ABO incompatibility, hemolytic disease of the newborn, and drug-induced hemolytic anemias. So autoimmune thrombocytopenia and autoimmune thrombocytopenic purpura, platelet membrane proteins, and then it's called the opsonization by the phagocytes, and then leads to bleeding. Yes, please.
RH stands for
Rhesus factors, Rh negative, Rh positive. Now, autoimmune hemolytic anemia, antibodies directed against the protein antigen on the surface, as we discussed right now. Fc receptor on the surface of the macrophage recognize the tail of the antibodies, and once this recognition takes place, the whole RBC is taken up and bleeding takes place. So this is how the cell occurs. This is the normal red blood cells, then it is attached with the antibodies, if it is sensitized, and then is taken into the cell and then ruptures, hemoglobinuria. Transfusion reaction, very common example, incompatible RBC or serum is transferred. For example, somebody has blood group A and you gave him blood group B. He has A antigen on the surface of the RBC and he has B antibody, and you give him B blood. When you give him B blood, what will be the antigen on the RBC? A B antigen, and it will be having A anti-sera, tamam, anti-A. So when the donor RBC, when it has a B in transfusion, which RBC will rupture? The donor RBC or the recipient RBC? The donor RBC. So when it comes from the outside with the antigen B and it has anti-B, so this anti-B will react with it, and then there will be hemolysis. What will happen to the free hemoglobin? It can go to the kidneys, will cause hemoglobinuria and damage to the kidneys, and it will break down to bilirubin. When it will break down to bilirubin, when there is too much hemolysis, too much hemoglobin, too much bilirubin, and if it is more than the capacity of the liver, so what will happen? There will be a jaundice and there will be unconjugated hyperbilirubinemia will be there, and this is toxic. It can go to the brain and damage the brain. Clear? So there will be unconjugated hyperbilirubinemia, particularly it happens in the children's. Okay, here the RBCs, antibodies are there, anti-B. So for example, this is a donor type A. This is donor type A. It has A antigen here and it has anti-B. And this is a recipient. This is the mismatched transfusion. You are one of them, not one of them, someone, not you. Someone who is sleeping, mobile man, mobile doctor, we call it mobile doctor. Sleeping or mobile doctor, and he did not recognize that what are the steps that one should take before transfusion of blood to a person. Tamam? He came in the ward and they said, oh, bed number 15 has to be transfused blood. Tamam, and this is his blood present in the refrigerator. Take his blood, transfuse him. He said, okay, maafi mushkila. He opened the freezer, the refrigerator where the blood is transfused, took out one bottle, don't know how to take steps. You understand my point? Why? Because he was very busy in the class. Tamam? No, don't know the steps, and took the blood and transfused. That was, he need A plus and he gave him B blood. When he gave him B blood, what will happen? The antibody of this one, anti-A, will attack these RBCs and then lead to rupture. And hemoglobin urea and bilirubin, hemoglobin urea and hyperbilirubinemia. A, B, O blood compatibility. A group, anti-B. B agglutinins, anti-A. A, B, no antigen. That's why it is called universal recipient. Universal recipient. Selfish recipient. Make him up, otherwise he will do some mismatch. Make him up. High chances of mismatching. Huh? That's why it's called selfish recipient. He can take blood from anyone. And then this one, O, he don't have any antigen and has anti-A and anti-B. So it is universal donor. It can give blood to anybody, but it cannot receive except for himself. Yes?
The anti-A and B, does it attack the recipient's blood cells?
Here?
Yeah.
No?
O has in the serum anti-A and B.
Sorry?
O serum has anti-A and B. So the recipient won't be
He will receive only anti-A, don't have antigen.
No. O is universal donor.
Universal donor.
The recipient
Uh-huh.
won't be affected by the anti-A and B.
Sorry?
The recipient won't be affected by anti-A and B in the serum.
This is the concept. If you donor, who will be attacked? The donor. This I question. I asked the question. Who will be attacked? The donor or the recipient?
The recipient. The donor.
The donor. The donor RBC will be attacked. RBC of the.
Even if the quantity was
No, listen. Try to understand the concept. If you give this blood to anybody, tamam, you don't have any antigen. You don't have any antigen, so his RBC will not be attacked. And you can't give any other blood. If you give him any other blood, it will be attacked. You understand my point? Is this clear or not? Who will be attacked? Try to understand this concept. Who will be attacked? This is recipient, this is donor. This RBC or this RBC, who will be attacked? This RBC will be attacked. This RBC will be attacked. When this RBC will come, it has an anti of this, it will kill this one. So this has no antigen. If you give him, because it has no antigen, this has no antigen, how it will be attacked? Whether it is anti-A or anti-B or anti-D, whatever is present there. You got this point? So that's why it's called universal donor. How many O? O positive, O negative? I am too many. Good. Okay. So who will use the brain? Let him. This my friend will answer this question. Otherwise, I love him too much. That's why. Answer the question. Use your brain.
Yes.
Yes. Using brain, sleeping brain. He using brain when he is sleeping. Yes. People with type AB blood have. It's very simple. Huh? What is the answer? Huh? Sure. Okay. Hemolytic disease of the newborn erythroblastosis fetalis, newborn disease. What happened? There is a mother which is Rh negative. Mother is Rh negative. And she has a baby which is Rh positive. Normally the blood don't mix. But by chance, if there is a mixing of the blood and this Rh positive blood comes here into the mother will get sensitized. And when she will sensitize, she will make antibodies against this Rh positive. First pregnancy, no problem. Similar we discussed earlier. First time, Mavi Bharatani. First time, no problem. You understand my point? So first time there is no problem. But when she had another pregnancy after 1 year or 2 years, and by chance, again the baby is Rh positive. So she has already antibodies are there, and these are immunoglobulin G types. Tamam? So they will cross the placenta and kill the baby. Is this clear? This is called Rh, the newborn disease, hemolytic disease of the newborn, hemolytic disease of the newborn. So here erythroblastosis fetalis, maternal IgG cross the placenta and attach to the fetal RBC and occur via the maternal IgG antibody crossing the placenta. Severe case causes erythroblastosis fetalis, and it occurs when the mother is Rh negative and baby is Rh positive. Clear? If you give him some anti-D in order to prevent it, if you give him, this is the baby, antibodies, plasma cells, and then destruction of the RBCs. So these type of the mothers, this is the erythroblastosis fetalis. These type of the mothers, when you recognize them that, oh, the mother is Rh negative and the baby is which positive? Killed. Just count down, huh? How many people will be killed? The baby is Rh positive. So when you know this, what you will do? You will give them anti-D, some injections. So these injections, what they will do, what is the function of these injections? They will neutralize the antibodies they are made. They will neutralize the antibodies they are made inside the mother. When she had another pregnancy, so she will be, the baby will be safe because the antibodies which are made already have been neutralized. So that's why it is very much important that you should know that if the mother is Rh, if your wife is Rh negative and by the pregnancy the baby is Rh positive, should keep this in your mind, ask the doctor to give her the injection, otherwise my second baby will be in the problem. Tamam? First baby might not have any problem. So Rh negative woman, Rh positive man, then problem fetus. If there is no Rh negative problem, no problem. But if the Rh positive fetus, Rh positive enter into the maternal circulation, mother, if there is no mother early sensitization first, no problem. But if it is early sensitized, then there will be isoantibodies, fetus, and then it will lead to hemolysis. Yes.
Anti-D is given in short period or in the overall pregnancy?
No, short period immediately in the after the pregnancy, after the birth of the baby. So although you don't know whether there is a blood transmix or not, but to be on the safe side, you give. Clear? The same situation. Okay. How can Rh antibodies molecule that cause hemolysis disease of the newborn prevent this disease when administered to an Rh negative woman who is pregnant with Rh positive fetus? Rh antibodies. We just said what it will do. It will cause the neutralization. Antibodies destroy the Rh antigen from the fetus before the mother is sensitized. So as soon as you know that there is the Rh negative mother with the Rh positive baby, give her anti-D once delivered. So before sensitized, it will neutralize the RBC antibody antigens, and then it will be, everything will be normal. Drug hypersensitivity, penicillins, granulocyte quinidines, and platelet sulfonamides. These are the cells, they are sensitive to many of the drugs. So for example, people that take quinidine and aminopyridine, they may be having problem in the WBCs. People that take sulfonamides and thiazide, they may be having problem of the platelets, neutropenia, bleeding. And people that take penicillin, chromazepine and phenacetin, they may be having problem with the RBC, lead to hemolysis. So hemolysis, maybe thrombocytopenia and maybe neutropenia. Here, as I discussed this earlier, your son is a Mumtaz boy, he is going to Salah, doing good studies, everything is good, but his friend came from outside and made him bad. Tamam? Here is the antigen, this is the RBC with the normal antigen which is present, no problem at all. But somebody took some medicine and that medicine come and attach to this antigen. You understand my point? And now this medicine converted this normal antigen into a bad antigen. when it is a bad antigen, so as soon as this bad antigen, the antibody saw it, it will attack it and then will destroy it by any mechanism or by complement destruction. Clear? Complement Fc receptor mediated inflammation, the second component. So first component we said the destruction of the cells without the process of inflammatory process, and you saw that there is no process of inflammation is involved. Phagocytosis, complement killing, natural cell killer. Tamam? Here there is a process of inflammation is involved. So here you can see here, this is the Fc portion mediated, you know the Fc portion, Fc receptor, Fc portion of the antibody. Then this is the antigen attached to the antibody, antibody attached to the Fc receptor of the granulocytes, and then there will be an activation of the complement system, the complement system from C5a, C3a, and then leads to inflammatory processes, and then process of inflammation will start. So this is the mechanism by the inflammation. Very good example is Good-Pasture syndrome, and it is the syndrome which is where there is a damage of the glomerular basement membrane, antibody is present in the glomeruli, and it is a proliferative progressive disease where there is a glomerular nephritis, inflammation of the glomeruli, and then it leads to hemorrhagic intestinal pneumonitis as well, because it damages the, let me tell you here, it damages the non-collagen component of the collagen, and you know collagen is a structural component, and it is present in the blood vessels as well, collagen molecule, long fibers. Tamam? When it weak, there are two situations where it is weak. One is this one, when it is weak, the cell membrane will weak. When the blood cell membrane is weak, what will happen? The blood will come out, hemorrhage will be there. So that's why it's called glomerulonephritis, Good-Pasture syndrome. You will be bleeding, both renal pulmonary lesion, cause the antibodies targeted against the non-collagenous domain of the type 4 collagen, and these antibodies detects in the serum for more than 90% of these people. And presentation, what will be the presentation? If it damages the vessels of the blood of the lungs, what will occur? Hemoptysis. What is hemoptysis? Blood in the balgam, and there will be blood. When he cough, there will be blood. When he cough, there will be blood. And if it is the damage the kidneys, what will happen? Hematuria and proteinuria. There is one more situation similar. Yes. Vitamin C deficiency. Very good. There is same situation, another situation, that is vitamin C deficiency, scurvy. Clear? Again there is a problem of the collagen, but that is the problem of the collagen, maturation of the collagen, and here there is a damage of the collagen against the antibodies. Tamam? Okay, so here is the complement Fc factor mediated inflammation, and then nephritis and lung hemorrhages. Pemphigus vulgaris, again another type of the infections where there is actually, you know, this skin. Why the skin is like this? It is not it is soft, but it is not soft like you can take it out, and it is not tough. It has a technical structure of there. This is because of cohesion molecule. There is some substance which adhere the dermis, epidermis together. Clear? They between the keratinocyte or in the epidermis. The and if there is a problem in this one, what will happen? There will be inflammatory, there will be blisters like this, there will be damage like this. See here. You got this point? The skin will be weak. Because that cement which is in between the epidermis, it is dermis and epidermis, it is not there. When it is not there, so it is very easily blisters formation will be there. This situation is called pemphigus vulgaris. Here the autoimmune disease cause antibodies directed against the desmoglobin 1 and desmoglobin 3, and these resulting in the loss of the cohesion between the keratinocyte and the epidermis. So when there is no cement in between, the cell will be weak. When the cell is weak, so there will be a blister formation. Third is the antibody mediated cell dysfunction, and again here what will happen? There is one cell here is performing normal function. For example, thyroid gland, this thyroid gland, tamam, it is under the control of, thyroid gland is under the control of pituitary, very good. TSH, tamam, TSH come, attach to the receptor, stimulate the receptor, thyroid gland will be stimulated, and then there will be a thyroid hormone. Is this clear? There is an antibody. This is the antibody. This is the TSH receptor. This antibody is coming and attaching to this receptor. Is coming and attaching to the receptor, and indirectly it is stimulating this receptor. Indirectly it is stimulating the receptor. When it stimulates the receptor, what will happen? There will be more production of the thyroid hormone. There will be more production of the thyroid hormone, and it will lead to hyperthyroidism. So antibody. There is one more situation. Here the stimulation is there. There is another situation, acetylcholine, neuromuscular junction. Acetylcholine come attached to the neuromuscular junction and stimulate the neuromuscular activity. But antibody comes attached to that receptor and do not allow the acetylcholine to function. It will decrease the function. It will decrease the function. So there are two different situations which is caused by the anti-mediated cellular dysfunction, in which the cellular dysfunction is there but overactivity. In another there is a cellular dysfunction and decreased activity. Clear? So you can see here, this is the example of TSH receptor, antibodies against TSH receptor, and then there will be overproduction of the thyroid hormone. And here there is a acetylcholine, it has to bound to this receptor, but antibody comes and attached to this receptor, and there is a decreased activity of the acetylcholine. This situation will lead to Graves' disease, and this situation will lead to myasthenia gravis. So this is the Graves' disease, pituitary TSH receptor overactivity by the antibody, and this is the situation. Exophthalmos, autoimmune thyroid disease. This is the same situation, thyroid function. And this is myasthenia gravis. Here the antibody attacks the receptor and then there is no activity. So where is the muscle weakness, no actin potential, decreased excitement. This is nerves, acetylcholine bind to the receptor. But here instead of binding to the receptor, the antibodies are there, and antibodies do not allow the acetylcholine to bind with the receptor. So in one situation there is overactivity, and on the other situation there is a decreased activity. Here the same situation here. What are the signs and symptoms? If the muscles are weak, what will be the sign and symptomation? Eye dropping, impaired speech, muscles are weak. Then difficulty in swallowing, and trust me, sometime we experience this, sometime I experience this. If this esophagus don't have peristalsis, tamam, it is a life-threatening situation, very tough situation, that you take a bolus and it comes here and stuck up here. It cannot go down, it cannot go up. Tamam? So it is a very serious situation. Diplopia, because the muscles of the eye don't control the eyeball, so you have two visions. Diplopia, easily fatigue, quick recovery with the rest, it is the characteristics of this. And waddling gait. What is waddling gait? Like you are moving like this. Tamam? Waddling gait, wide waddling gait, because the muscles are not contact. Pernicious anemia, another important situation. Last but not the least, antibody cell mediated dysfunction. There is vitamin B12, vitamin B12. It is like two friends. One friend says, if you are sleeping, I will be sleeping. These two friends, they are sitting together. See him, they are sitting together. He said, I will sleep, you will sleep, don't worry. Tamam? Recording is there, we will see in Baden. There is B12. B12 is required for the maturation of the RBC. B12 is required for the maturation of the RBC. But B12 cannot be absorbed until unless intrinsic factor is not there. Until unless intrinsic, they have a very strong friendship. So this is B12 and it has to be absorbed, but it will absorb when the intrinsic factor is there. If they come with the intrinsic factor, so if for example here, for example, this is B12, this is intrinsic factor. If they combine, they will go inside. And when they go inside, B12 will go and mature the RBC and there will be good hemoglobin. Clear? Here what happened in this situation, antibodies are made against this one intrinsic factor. Antibodies are made against the intrinsic factor. Tamam? And there was the old stories or fairy tales. There was a magician, Samari, at the time of Hazrat Musa alayhi salam, magician. And he said that the life of this magician is in a parrot. You know the parrot? If you kill the parrot, the magician will die. So they are related to each other. So this is the B12. The B12 will be absorbed once it is attached to the intrinsic factor. Antibodies are directed against the intrinsic factor. Catch the intrinsic factor. When they catch the intrinsic factor, the B12 don't go inside. When the B12 don't go inside, there will be no maturation of the RBC. There will be megaloblastic anemia. This situation is called pernicious anemia. Pernicious anemia. So antibody dependent cellular dysfunction. Antibody dependent cellular dysfunction. We discussed three situations: myasthenia gravis, increased activity of the TSH, increased activity of the thyroid hormone. Myasthenia gravis, decreased activity of the acetylcholine. Graves' disease, increased activity of the thyroid hormone. And pernicious anemia, decreased activity of the B12, because B12 cannot be absorbed. Why? Because antibodies are directed against the intrinsic factor. Clear, guys? So this is the, I hope this is the end. What happened? I am going reverse. Aiwa. Tamam. How you diagnose it? We diagnose the see that the circulating antibodies, presence of antibodies and complement lesion in the biopsy, and then treatment involves again the same immunosuppressive and anti-inflammatory. So how to summarize it? In order to summarize it, this is the summary. This is the summary. Type 2 hypersensitivity reaction. Type 2 hypersensitivity reaction. Antigen is fixed, antibody is free, attached to the cells. Three major mechanisms of the disease. One is phagocytosis, another is complement FC mediated inflammation, and third one is the dysfunction. The phagocytosis we discuss with the complement, without the complement. Clear? The complement FC mediated inflammation, we discuss the formation of the MAC and killing of the cells. And last but not the least, anti-mediated cellular dysfunction, Graves' disease, myasthenia gravis, pernicious anemia. In first one we discussed four situations. Situation number one, phagocytosis, two mechanism. Situation number two, C3b, opsonization, and then MAC, direct killing, and the natural killer cells. Natural. And this natural killer cell kill is called ADCC, antibody dependent cytotoxicity, antibody dependent killing of the cells. Clear? So type 1 hypersensitivity was IgE mediated, type 2 hypersensitivity is IgG and IgM mediated. Tamam? In type 1 hypersensitivity, pre-sensitized host is required. In type 2 hypersensitivity, there is MHC presentation of short peptide of the antigen. Tamam? Thank you very much.
Thank you.